Welcome back to another episode of Season 5 of Inside Medical Malpractice. I'm Chris Rokosh, your podcast host, and I want to once again thank each and every one of you for listening in today. I appreciate it so much that you're here. In this season, Season 5, we're going to shine a light on some of the patient safety initiatives that have been born out of serious injuries and malpractice cases. We're going to look at the communication and response to medical errors, and we're going to also examine how improved patient safety can, or is hoped to, affect both healthcare outcomes and medical malpractice litigation. We're going to break down these sticky, complicated issues and the ideas for change with guests who know this subject inside out. Today, you're in for a powerful conversation with Michael Wong, JD. Michael is a graduate of Johns Hopkins University and a former practicing attorney who is now a recognized healthcare and patient safety expert. He's been at the forefront in driving practical solutions to reduce healthcare costs, decrease medical errors, and improve patient safety outcomes. Michael founded and now runs the Physician-Patient Alliance for Health and Safety, or the PPAHS. It's a nonprofit, internationally ranked top 100 patient safety organization. He started PPAHS in fulfillment of a promise he made to the mother of a young woman who tragically died from an opioid-induced respiratory depression, a story I'm sure we're going to hear in a few minutes. Michael says he doesn't believe that waiting for the next research breakthrough is the best idea. It's not the one that can solve today's patient safety issues. Rather, we can use current knowledge and technology to begin saving lives right now. To that end, some things that the PPAHS has done to promote safety include highlighting the need for continuous monitoring of patients on opioid therapy, having patient safety checklists that were developed by a committee featuring Dr. Peter Pronovost and Atul Gawande. I got to tell you, I love that guy, Atul Gawande. I have given away literally dozens of copies of his book, Better, at my Legal Issues and Nursing conferences, and I've read it 5 times myself. Love that book. He's also developed a position statement showing the need for continuous monitoring, including steps for reducing alarm fatigue, podcasts highlighting the cost versus benefit of continuous monitoring, along with numerous other articles, podcasts, and conference presentations. His efforts are based on a key belief that in order to move the patient safety needle requires a PR marketing effort tackling the issues from various viewpoints. I love that idea. I first heard of Michael from Leilani Schweitzer, who has been a guest on this podcast a couple of times. She phoned me up and she just said, Chris, you got to talk to this guy. You got to talk to him. He's going to make a great guest on your show. And so here we are. Welcome, Michael.
Thank you. Thank you, Chris. I mean, I couldn't have asked for a better introduction to it, and love what you're doing. And hope that I can shed a little bit of light on this patient safety aspect. I'm not, as you said, I'm not a clinician. I'm not a doctor, a nurse, or respiratory therapist. I'm an attorney. I used to do issues and crisis management for large pharmaceuticals. So I, for many years, kind of represented the bad guys, I guess, as the cocktail crowd would say. And 13 years ago, I think some of them would say I saw the light and went from becoming Darth Vader to Luke Skywalker and started this nonprofit. And, as the name, a Physician-Patient Alliance for Health and Safety says, I mean, at that time, there were physicians around me and patients around me. And that's, I don't know how to say it any more simple than that. And we said, well, we'll put patient safety in there as well. My apologies to nurses and respiratory therapists or any other clinician that's out there, but we were trying to play on the physician-patient relationship, which is so key to having a good, healthy patient and a good, healthy healthcare system. So we played on that, and hopefully it's a good thing. But I have had some pushback on that from nurses and respiratory therapists in the past.
Oh, man. But, I think it's like your non-medical background, like your legal background and whatever else you have in your history, I think your approach to this is really unique and probably has brought you some successes that may not have ever happened. I mean, to focus on doctors, to hit it with PR and marketing efforts, to hit it from various viewpoints, and also, and we'll talk about this, but you tackling kind of one particular issue at a time. I'm fascinated by that because certainly a lot of efforts to improve patient safety are quite global, tackling communication and assessment and errors and machines. And I think that's awesome because that's what the problem actually is. It's very global. But I think, so I don't think you need to apologize to nurses. I mean, maybe you do. Maybe I'll find that out later, but I didn't feel offended by any of this. I thought this is a unique approach, and I'll be interested to hear how it's working for you, period. So I think it's amazing, and I think your difference in your background, your legal background, is going to lead you to having a different approach to solving this problem.
I think it really has, in a way. If I had been a physician or a nurse, I probably wouldn't have brought together all these committees that had Atul Gawande or Peter Pronovost on it, because I would have felt, maybe I would have felt, I know it all myself, as opposed to me, I'm okay talking about legal issues, and I'll stick to my lane. But once we kind of get outside that, I'd rather have a physician or a nurse beside me, speaking to the press or going to conferences and that kind of thing. So, bringing together committees to do opioid-induced respiratory depression or blood clots in maternal patients or anything like that, I'd bring together a committee. I wouldn't rely upon my own knowledge. And if I have an idea, I'll turn to, one of the physicians or nurses or respiratory therapists on our board and say, hey, what do you think about this? And they'll tell me whether I'm crazy or not. Of course, one thing I've always felt and told people is that we need to not just complain about an issue. I mean, it's so easy to gripe about something that's not being done in our world. It's harder to come up with some kind of solution for that. And I mean, the story you alluded to earlier in the introduction was a young woman, Amanda Beal, who was a high school student going to college. And I was at that time living in Chicago and got a call from the University of Notre Dame saying that she had passed away and they would like to do something for the family. And the story I found out was she had been admitted to hospital with severe strep throat, or that's what they called it, diagnosed it. And she was in some pain. So they gave her some opioids through a patient controlled analgesia pump. Of course, any anesthesiologist will tell you that, you give someone with a compromised airway a sedative and you may be mixing, trouble together. Unfortunately, her friends came to see her one evening, and the next morning they came to see her, and they came to a empty hospital room. And some of them I know are still on antidepressants because of that incident. And when this University of Notre Dame invited me to speak with the students, there was a nurse and there was a respiratory therapist there, and we talked about, what was, how we felt about the issue. I talked mostly about adverse events and litigation, and the nurse and respiratory therapist talked about things which are not in my lane. So, but after the discussion with the class, Amanda's mother and father took us out for lunch, and Cindy's her name, and she's crying at lunch and saying, what can I do? I'm only a school teacher. My husband's an electrician. And in words that will become always famous for me, I said to her, I'll do what I can. And now 13 years later, still doing what I can.
You must have said, I'll do what I can 100 different times in your life. What was it about this case, this family, that mother? Why was this the thing that compelled you to make this change and to make the move into the field of patient safety?
I think it was just how it really affected the family, her friends, the fact that the community was there. I mean, all the, CBS, NBC, all those folks, they were there with their cameras. They were filming. It was a big local story. And for many years after that event, they would do sort of follow-on articles. It affected the community deeply, and I became affected as well. You know, it, and it's a good question you have, because around that same time, I was contacted by other mothers. There was Leah, who was a daughter of Lenore Alexander. She passed away under similar circumstances in California. And then Victoria Ireland from the UK contacted me. Her son had passed away, again, similar circumstances. And, I had other folks contact me as well during that time period. I'm going, hey, there's something going on here. We need to look into this. And so that's what I did and started doing that. But as I mentioned to you, my first reaction to things is, can we propose some kind of solution for it? So I pulled together this committee that you referred to, alluded to earlier, with Atul Gawande and Peter Pronovost. And of course, I had other physicians on there as nurses as well. They're the, how do I call it, celebrity physicians, and everyone seems to mention them.
They're the ones we know.
They're the ones, and great guys, both of them, both great individuals, and love them dearly. So then we put together the patient controlled analgesia patient safety checklist, and that talks about how you should put a patient on patient controlled analgesia, how to maintain them on that device, and how to take them off as well. So it was quite an undertaking, because all of that information was, how do I say, squished into one page, and on that one page with just a few bullet points under each heading. So it was a tall order that I tasked everyone with, but I think we did it. I just don't know how many hospitals it's being used at and how many patient lives it saved. But as one patient tells me, and I remember his words always, if we can save one life, Michael, it's worth it. So we're trying.
Well, I just want to say thank you for being true to your word, number one, and tackling this, which probably at the time felt like way over your head or outside of your area of expertise, but you did it, and it sounds like you did it well. We talked about this briefly on our first phone call, and we were prepping for this podcast a few weeks ago, but I have given, I've had thousands of patients on PCA pumps, thousands, and nobody that I know of ever had any, certainly nobody died. God, thank you. And nobody ever had real complications. But my training around, like when you're talking about safety checklists, like same thing, we had a little 5x7 card that was attached to the pump. And it was more than anything how to work the pump. And there wasn't a lot about the patient monitoring, and there was never any SpO2 or oxygen monitoring. We did respiratory, just respiratory rate monitoring and, level of conscious monitoring every now and then, depending on the situation. But when I moved into the field of medical malpractice, doing the legal nurse consulting and look at cases, several cases came through as potential lawsuits, not of death from opioid overdose, but certainly hypoxic brain and other organ injuries from prolonged periods of people at a respiratory rate of 6 or 8 or whatever overnight, and they weren't checked on, and their SpO2 is 62 or 52 or whatever in the morning. So they ended up with hypoxic brain injuries. So I know of this issue, but I never, ever knew anybody like you who took it on and tackled it and tried to make it better. So thank you. I would have liked in my, active bedside clinical nursing career, I wish I'd had more information at the time.
Yeah. Well, as I've told the Beale family, I wish I'd never met them, because that would mean that the daughter was still alive. I think we live in a technology society. We believe in technology. I use my my phone's with me. I'm speaking to you from my laptop. I mean, we're all, it's a tech society. And I think patient-controlled analgesia, the hard thing about it is it's in a box, if I could call it that. And we kind of presume that if it's in a box, it's going to work. Well, that's not always the case. Some people say to me, well, the patient must have overdosed by, drinking too many pills, taking too many pills. And I said, no, it's an opioid prescription that is prescribed by his or her physician, and it's not something that they sort of grabbed out of grandma's medicine cabinet and took too many pills. It was done under a physician's order. So, and that seems to shake some people when I speak to them about that. So.
Yeah. Well, and understanding how that PCA pump works, and there are safety mechanisms to prevent overdoses, but they seem to happen. Or I think you have to realize that every single person is sensitive in their own way. There isn't like a standard dose that's going to work for everybody. I'm glad you talked about technology, because I think that's it's a good topic right now. It's a rapidly evolving thing in healthcare, and there's upsides and downsides. We all know that. And it's certainly played a part in these PCA-related deaths or injuries that you're talking about. Are you using technology now going forward to fix this problem? And are you finding any innovations or tools especially promising for the future? Because it was interesting. I recorded a podcast with Leilani Schweitzer and Radonda Vivat just a couple of days ago, and they both had, serious medical errors and deaths related to an over-reliance, I believe, or some glitches in technology. And they cause problems, and they really talked about we need technology. It's here, it's here. That's all there is to it. But we also need to never lose the skills that we used before technology came on: the hands-on monitoring, the eyes, and the actual manual monitoring of blood pressure and pulse, and the SpO2. So, what are your comments on the good and bad about technology, how it's going to help you moving forward, and anything you might be hopeful about in the future?
Well, you'll notice in the checklist that we talked about with Peter Pronovost and Atul Gawande was involved, it's a combination of technology and other continuous monitoring, but also people skills or people smarts. And, we did the OBVT safety checklist for pregnant mothers, and a checklist also for stroke patients. And it combines the same thing. It's a combination of use of technology or medications or whatever in that side, but also human smarts too. You can't replace the eyes of a nurse or the eyes of a physician that is looking at a patient and saying to themselves, something isn't right. And that's something we can never replace with a machine. I'm sure there's folks who are doing AI would probably tell me otherwise, but I don't think that we can replace that. And that's the human factor that is just the unknown, and we really need that. So
tell us a little bit about the OBBT and stroke checklist, can you?
Oh yeah, well the OBVT checklist we came up with for maternal patients, because we heard about, or a family had reached out to us because the mother, who was in her third trimester, had fallen unconscious in her kitchen and was found by her husband. And what had happened, simply speaking, she had developed a blood clot, and the baby was delivered, if my memory recalls me, by cesarean section, but she had need for physiotherapy for quite some years after that event. And so we helped with raise awareness amongst our followers and helped raise funds for that. And of course, my response as soon as we did that was, we got to come up with a
checklist.
A checklist. So pulled together a committee, and it had folks from the Institute for Healthcare Improvement, the National Perinatal Association, and midwives and folks like that. And I said, how do we do three things well? A mother comes in. How do we assess her for VT risk of blood clots? and how do we rank that? And if she has a risk of VT, what do we do with her? How do we treat it? And then when we discharge her, what can we do at that point of discharge? So it was a simple checklist. Again, all this research and information combined into an 8.5, 11 sheet with basically 3 columns: admission, treatment, and discharge, and bullet points underneath that. And I think the hardest thing was condensing all that information and all that knowledge into an 8.5 by 11 sheet, and just turn it into bullet points. But I think we did it. Yeah. And similar to the stroke VT safety checklist that we put together. And I think there's going to be need for others like that, and continue to look for, other opportunities to do things.
Good for you. You talk like a doctor. You do. I've said this before in the podcast, but I am so often in awe of how attorneys who work in healthcare law, whether it's, plaintiff or defense, are so knowledgeable and so learned about medical issues. So
someone on my board of advisors who's an OBGYN has written textbooks on this. She became an attorney. So she went from a doctor. So now she's both. And I'll speak to her. She says, you should say, Mike, you should go to med school. And I go, well, I'm too old to go to med school.
I think it's a tough job at this time in your life. I mean, just to get to residency is like, oh, yeah, I don't know.
I wouldn't mind getting the knowledge, but I'm not too sure I want to be tested.
Yeah, exactly. I want to take it back just a little bit to how I'm fascinated by how you're tackling kind of one problem and one issue at a time and adding things as an awareness develops apparently, and then you build a board and you work like this. Talk to me a little bit about the effectiveness of this strategy, because it's different, I think. Some people build like a diabetes awareness foundation, but it isn't necessarily like a safety focused one like you have, and other people tackle the large problem of patient safety. How has this served you well to take on one issue at a time and, get right inside of it? And how are you measuring also your outcomes, or can you measure your outcomes, your successes?
Well, I think our demand that we come up with solutions is really what distinguishes us from other patient safety organizations. Because if you go into one area and take the mindset, you have to come up with a solution or some answer to it, then some helpful tool to help solve the problem. If you have that attitude, you're going to want to tackle one thing at a time. I mean, one of the big issues we've gotten into is sepsis, and we work very closely with the Global Sepsis Alliance. To date, all we're doing is providing continuing medical education for clinicians from all around the world. That's a solution, but I'd like to come up with a better solution for it. Can we come up with a checklist for it? Can we come up with some recommendations for it? Something that would actually, address the problem directly. And I haven't yet come up with that. So I can be faulted for working on a problem that we haven't quite come up with a solution for yet.
Well, sepsis is a big thing. It's huge. It's really a big thing. What sparked your interest in sepsis? What brought that to your attention?
Interestingly enough, a board of advisors member, I met him at a conference. And he says to me, hey, Mike, I almost, you kind of say, like I'd meet you, Chris, and say, meet you, hey, how are you doing? Well, when I asked Ken, how are you doing? He said to me, Mike, I almost died. I said, what? It wasn't quite the response I was looking for.
Yeah, exactly.
And I said, well, what happened? He had gone in for routine, I think it was ulcer surgery. And he, with a lot of medical procedures, he wound up getting sepsis. What was interesting about his case was he's the chief medical officer. I believe at that time he was down in Florida. He's now in Texas. And so I said, Ken, we got to record this. I think it's fascinating. You have a great perspective. You're a doctor and as well a patient at the same time. So we recorded a podcast just like we're doing right now. And, I put it up on the internet, our YouTube channel, and the Global Sepsis Alliance saw it and they commended it. And I'm thinking, wow. And so that's how we got to first working with the Global Sepsis Alliance, and have been doing that ever since. And in particular, we'll work very closely with them in the last two conferences, 2023 and 2024, and we're again planning for 2025. So, and they're great conferences too. I mean, there's like 12 to 15,000 people that join the conference online from all around the world. And so one day there's like 15,000 folks online. It's crazy.
Well, congratulations again. And congratulations on getting such a global reach. Because I'm sure, it's a problem here in our well-developed North American healthcare system, but I imagine it's a problem in other countries of the world that don't have the resources that we have.
Yeah, yes. And obviously the issues that are tackling, the physician in New York are going to be different than the physician in, Nigeria versus,
The sources of infection are just going to vary wildly, I'm sure.
No, it really is. But something to keep in mind. I mean, I think because of that, I'm always fascinated by the internet, because it's not like we purposely put our stuff out to the rest of the world. I mean, I'm based in New Jersey. We're a US nonprofit. You put something on the internet, it just goes everywhere. And so after the United States and Canada, the greatest audience we have is in the UK, which kind of makes sense. A lot of folks from the NHS, that also makes sense. But then I look down the list and there's like India and Pakistan there. And the first one I saw that, I was like, India and Pakistan? Well, of course, a lot of clinicians are taking their having their medical education in the UK. And so they're speaking English and they're reading that. And we haven't yet had a chance to, or the ability to translate our materials, but I'm sure if we did, we would be able to reach a bigger audience. And it's because of that. Well, now, I mean, as you mentioned earlier in the introduction, in the top 100 patient safety organization internationally, which just floors me. I thought when I founded this 13 years ago that we would be done in like 6 months.
And you're not. Here you are and doing well.
Here we are 13 plus years later, kind of doing the same thing. Obviously, we've moved from opioid-induced respiratory depression to include other areas, but we still continue to be focused on a few key issues.
What would you see? Well, I'll just let you know that the same thing with this podcast. It's, when you look at where the listeners are, it is literally around the entire world. So we'll be getting you a little bit, maybe in some places you haven't been before, but if you're just tuning in, this is Dr. Michael Wong, and he's the founder of PPAHS, one of the top 100 patient safety organizations in the world. So if you want to learn more about him, he's easy to find. Michael Wong, PPAHS, you can get a hold of him. Another question for you. What would you think? Like, there are multiple problems in healthcare today, and I don't ever like to focus just on the problems, because I know from working as a clinician for 35 years at the bedside, I know that magic happens every day in healthcare. Babies get delivered and people get healed and cancer gets cured and things happen every day. I know it's mostly good. But that said, I also know, as much as anybody knows, that there are problems, and medical error is certainly one of them. In your view, what would you list as the most pressing challenge or challenges facing patient safety today?
Well, recently, of course, we all experienced the COVID pandemic, and I think the pandemic really highlighted some key deficiencies in our healthcare system. One of the things we started during the COVID period was I said, hey, let's run a nursing chat line. Folks are stuck at home and they can't get a hold of their physician for whatever reason, probably can't even go in. And so this way they could stay at home and get on the nursing chat line and ask whatever questions they wanted. And I would at the end of the day kind of read the text transcripts of the chats, and I realized as the COVID period was going on, there were more and more people that were entering the chat line because they hadn't really had nowhere else to go because they had lost their healthcare insurance, they'd become unemployed. When we have a system, well, here in the United States, obviously elsewhere in the world, can be very different. Healthcare here in the U.S. is tied to employment. And as these people were losing their employment, they were looking for medical advice anywhere. And they came to our chat line because they obviously saw it was a chat line with nurses, but also another nice word called free involved. And that's what happened. Of course, I must admit it was done through a generous educational grant from BMS and Pfizer. A lot of folks think that pharma and big business are enemies. But when I went to my BMS and Pfizer folks and said, "Hey, I got this idea," they came back and said, "Mike, that's a great idea." And I always tell people that story because you can't think of big companies or big pharma as the villain. There are great people in every organization, and you just have to find them and work with them. And I continue to do that. So that's something to remember.
Nice job. And they are sometimes the source of big money, which is hard to find. Sometimes, isn't it? Yeah.
But that leads me to, I guess, my other point. You have to bring all stakeholders in the healthcare system to come up with a good solution. You can't just say to yourself, well, I'm not going to deal with the BMS, Pfizer's, and Abbott's and Novartis's of the world because they're big companies. You have to bring them to the table and get them involved. I don't like necessarily payers. We've gotten involved in various issues where payers have moved medication from tier 1 to tier 3 or whatever. I might not like that fact, and it's they're charging patients more, but we got to bring them to the table. We got to bring them to the table and figure out a solution. And so we have to keep that in mind as we work through this.
Good. You have a very calm, straightforward, intelligent, and completely non-threatening manner about you. Like I'd give you money if I had money. Yeah, sure. You're gonna be calling me later, aren't you, Chris? Hi, it's Mike here. Yeah. Okay, let's move on to the next question because I've got a few more I'd like to get through, and I want to be respectful of your time. I'm sure you're a busy guy. Ideally, the culture of patient safety in every facility includes an emphasis on reporting and learning from errors, a commitment to continuous education, and active engagement by patients and their families. And a personal experience, again, with a PCA pump a few years ago, my father-in-law had he was 84, 5, 6, I forget, he was an elderly man at the time, had both of his knees replaced, and he was on a morphine PCA pump following surgery, which was great for his pain control. But at one point, I was sitting at his bedside, and his respiratory rate was like 7 or 8. And the anesthetist who was in charge of his post-op pain control was called to the bedside. And I said, I'm concerned about his respiratory rate. And he just said, no, it's not a problem. And I had to fight that guy. And I said, yes, it is a problem. So it was kind of I don't know if it was like, you're not going to tell me how to do my job, if it was a kind of a power play, or he really wasn't concerned, but I was concerned, but he wasn't taking my concern seriously. But I guess my question is, are you seeing resistance to these, the new guidelines and the help sheets that you're putting out? Is there prevalent cultural or systemic practices within healthcare that you are either finding resistance to or believe need to be reformed to move this dial forward?
Well, that's where I think that information, marketing, whatever you want to call it, very early on, after I put together the PCA safety checklist, I was invited to speak at the National Perinatal Nurses Conference. And I remember after I presented this, a bunch of nurses come up to me and they were basically saying to me, Mr. Wong, you're trying to take our jobs away. I said, no, 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 no. I mean, I don't think continuous monitoring is doing that. We wouldn't, I know that nurses take care of not just one patient, they're taking care of 20 or 30 at a time. And I said to them, wouldn't it be nice that you would know out of the 30 that, Chris is not doing so well or Mike's not doing so well. And that's what the monitoring device will tell you. And at that time, then they all said, yeah, that's a good idea. But then I think, it becomes a PR exercise in that way, or a marketing exercise. So I brought together some nurses, some senior nurses, and we did some articles on that and talked about that directly, about how continuous monitoring would be better better to help nurses improve the day-to-day workflow that they were facing, and how they could determine whether it was Chris that was having a problem or Mike that was having a problem. And so we did that. And it is sort of a marketing effort. I mean, if you want to call it that. So, you mentioned marketing efforts. So a lot of articles directed towards nurses on that, but also a lot of business articles directed to, how much money you can be saving by monitoring, and that kind of thing. So there's a lot of great research that's been done from around the world on that and that very topic. So, we publish that. And it's not sort of peer-reviewed publications, but it's what I call articles in the popular press. They get out and they're often read more than the peer-reviewed stuff, because peer-reviewed stuff, well, as you know, as a nurse, it can sit on your desk and not be read for quite some time. But a news article that comes up in the local press, you're going to probably read it first. So that's what we started doing. Of course, we have done peer-reviewed stuff, but I'm not saying we don't. But it's the popular press articles, as I call it, that often can sway or change how people think about certain issues.
Sure. And I would imagine that hits, in some cases, the public as well. And so if the public goes in informed and maybe asks for continuous monitoring, or at least knows about continuous monitoring, then that could change things too. Do you have a particular success story you could share with us from your experience that highlights how your patient safety initiatives have improved somebody, something, somewhere?
Well, you mentioned continuous monitoring, and one time I said at a conference, someone asked me that very question, how do I make sure that my mom or dad or whoever is going to the hospital is taken care of? And I said to the audience, well, the only way to really do it, if they're not continuously monitored, is to have, someone sit in the hospital room 24/7. And one person actually took that to heart, and I think it was her mother that got put into hospital, and so she had to work, so she couldn't be in the hospital all the time. So she hired sort of like a nanny, a woman who was Hispanic, didn't speak any English, but her job was to sit by her mother's bedside and make sure she was okay. And unfortunately, she was continuously monitored, and the alarms go off. And as you probably know, there's alarm fatigue. If you ever go into a hospital, alarms are going off like all the time. And when this woman found out that no one was coming into the mother's room, she ran out to the nursing station and just grabbed the nurse and made sure that the mother was taken care of. It's difficult to see how or measure how much our safety checklists have done with patients. We haven't stopped and tried to figure out how many patients have been saved or helped. That's a question for future research, and unfortunately, I'm usually kind of bent on what can we do next, as opposed to looking back and how many patients it saved. But we're going to need to do that. Maybe I should make a phone call to you, Chris, and we'll get somebody to do the research.
I'm busy that day, Mike. No, I'd be fascinated to do that. But I think too, you could find someone else to do that, because if your job is looking forward and making change, like, I'm a firm believer, and you can't do everything, but you can do what's yours to do and do it really well and move the dial forward on your thing. So, I mean, because there's so much we could be doing and we just can't do it all.
Yeah. So if someone hears this podcast and they, that's great research. And I'd say, well, if you got some money, well, let's figure it out. I mean, yes, I think that, we're a scientific, clinically research-driven society. And at the end of the day, we're going to have to prove how many lives the patient-controlled analgesia safety checklist has saved, how many mothers the OBVT safety recommendations have saved. Yeah, I think we're going to have to do that. And until then, they're just out there helping folks and without any data to back it up. Other than it kind of all makes good sense and is backed by great research. So, uh, yeah, I wish I could, but there's only so many things you can do in a day, I guess.
I know. But listen, if you're listening, Michael Wong is easy to find, on the internet. Look him up. And if you've got some help to offer, offer it up, because I think it's a fascinating subject. So looking ahead into the field of patient safety, particularly in the, particular issues that you've chosen to tackle, how do the next 5 to 10 years look, and what developments are giving you hope?
Well, I think there is a realization that a lot of the medical errors are systemic problems as opposed to personal issues. I mean, obviously there could be some personal liability involved. I speak as an attorney, I guess, but if we understand that when a doctor, nurse, or respiratory therapist goes to the hospital, that they're not going into the hospital saying, this day I'm going to kill Chris because she's sitting in that hospital bed. And they're going to the hospital to try to do their best and save as many lives as they can. And sometimes it's just the systems that we're working in, and we have to realize that. And once we realize that, we can start looking at the problems and trying to figure out solutions to the problems. Because if in our adversarial world, an attorney like myself is going to go to the board of directors of the hospital and say, you're not going to say anything. You're not going to admit any liability at all. But, if the problem is out in the open, we can come up with a solution for it. Well, we have to know what the problem is first before we can do that. And I think our litigation system and the way we just kind of have it set up, it prevents us from doing that. Because I know that, having spoken with families, sometimes they'll be contacted by their physician, and the problem will be explained, and the physician will say, "I'm sorry," and they'll often say to me, "We chose to sue the hospital, but we wanted to exclude the physician that was involved in it," and that's just because they had the decency and honesty to explain the problem to the family and to take some ownership for it. And I think we need to do that.
Yeah, that's a big issue, and an interesting one. And I hope that one that's moving in the direction that you just described right there. Given that this podcast is called Inside Medical Malpractice, how do you think, or hope, that advancements in patient safety might influence the landscape of malpractice litigation?
Patient safety to me is the ultimate win-win-win. It really is. We live in a society where we think of it as a zero-sum game. Being an attorney, it's very adversarial. The plaintiff wins, that means the defendant loses, and vice versa. But patient safety is that ultimate win. Hospitals get to see the patient discharged. The physician and nurses involved gets to see the patient discharged happily home, and the patient's families feeling well about it. The only one who kind of loses out in this equation when you get patient safety are malpractice attorneys. And I could say there's not a lot of tears that are going to be shed for malpractice attorneys. They're certainly smart enough, they can do something else. But patient safety is the ultimate win-win-win. I think people need to keep that in mind when they go forward.
That's good. That's good. That's a really great answer to that question. What's next on your agenda? Are there any projects or goals coming up? And I guess part two of that question is there a way for people listening in to get involved if they're interested in helping out? I mean, we've already tried to recruit ourselves a research aggregator, but is there a way for people to get involved if they're interested in joining or helping or supporting your organization?
There it is. You go onto our website, ppahs.org. There's a little get involved button, and every week folks push on that button, and sometimes people say, I want to write an article for you, or I want to help out with one of the committees, whether it's opioids or blood clots or whatever. And yes, of course, you can donate money. Folks do that. But there's so many other ways that folks can get involved. And we have volunteers literally from around the world. I mean, we get a lot of IT help from India and Pakistan, but we've had IT help from folks in Latin America, designers in graphic designers in North Carolina, but also Canada and Netherlands and in Nigeria and you name it. We're probably have a volunteer from every continent of the world, and they can go online and just push that little button that says get involved. What I see sort of next in that are us doing, we've been heavily involved in enhanced respiratory care. And we now have the first standard nationally for taking care of patients on mechanical ventilation, which again, one of our committees set forth. And we're now going around the country accrediting healthcare facilities according to the standard. And so far, we've accredited now, I got to count in my mind, 15 to 20 of these facilities across the country, from New York all the way to Hawaii. Can we do better? Yes. I mean, there are thousands of healthcare facilities across the country. Do we want them to meet that standard? Absolutely. Are there healthcare facilities in the UK or in Latin America or in India, that could benefit from it? Absolutely. But we're tackling one country and one problem at a time. I'd love to have it done elsewhere in the world too, as well.
Those are some lofty goals and some great goals. And again, thank you. Thank you for taking them on. Next question, finish this sentence for me. As it pertains to patient safety, in a perfect world,
there would be no patient safety advocates.
Advocates,
because no patient would be harmed, and I wouldn't have to do this.
That's a big goal and a great goal. So I'll just ask you one more question, Michael. I mean, we've been talking for an hour now. I'm sure we could talk for days, but we'll keep this to about an hour. But I ask everybody this at the end of the podcast, whether it's a patient, whether it's attorneys, whether it's doctors, nurses, but what is the most important thing? And I want to break this into three parts. What is the most important thing that you would like lawyers, doctors, and nurses and the public to know about patient safety? So let's start with attorneys. What is the most important thing you would like attorneys to know about patient safety?
I think it goes back to my earlier discussion about it being a systemic problem rather than a personal issue. And I know it's probably impossible in our litigation system to do that. But I think if we start realizing that there are systemic issues to the way we do things in our world, then we can come up with solutions. If we're continuously trying to say, oh, well, Mike did this and Chris did that and they're to blame, then we're saying it's the problem with the individual as opposed to the system that they're working in. If we understand it's a systemic problem, then we can come up with real solutions to it. That's going to be hard because lawyers, we're trained to win for our client, and sometimes winning for our client is not in the best interest of society. When a patient dies under patient control, using a patient-controlled analgesia pump, it's was there a checklist in place? Was that being followed? There might be other issues rather than, yes, maybe someone made an error in terms of setting the pump. I've heard of that. Maybe there was a issue with creating the solution that that was given to the patient. I mean, all sorts of things like that could happen. Yes, that could be, but also there's the nurse and respiratory therapist who just put the patient on the patient-controlled analgesia pump just as he or she was told, and an medical error could happen. We got to understand that could be happening in our system, and when we understand that, we can fix it.
Good answer. How would you answer that question for healthcare providers? What's the most important thing you would like doctors and nurses, and let's include respiratory therapists in this too, because they're a big part of what you're doing. What would you like them to know about patient safety?
I think every day we all have to remember that every day they go to work, they're not out there to kill someone or harm someone. They're out there to save lives. And I think that's maybe a message more for the public than for the healthcare professional. But keep that in mind, and don't start blaming folks for what's been happening. And that's really a message I would give to people.
And what about for the public, or was that your answer for the public? Would you have a different answer? What would you like the most important thing you'd like the public to know about patient safety?
Yeah, well, I think I've said it. They have to understand the system that healthcare providers or healthcare professionals are working in. They're trying to do their best. There are things that do happen. Yes, it's of course unfortunate it happens to you or one of your family members or a friend or a loved one, but they're trying their best and they're working within certain constraints that society has given them. But let's all work together to come up with solutions. When we see a medical error or other problem come up, let's work together to fix the problem and make sure it doesn't happen again to someone else.
Yeah, that's so important, isn't it? That's so important to take a look at it, examine it, and move forward, move forward from there and make changes. Well, is there anything else you'd like to say before we sign off, Michael? Anything? Last words?
If anyone wants to get involved, just get online and push that get involved button, and happy to have folks get involved with what we're doing. And that's really, if you believe in our mission of patient safety, click that button and help us out.
Awesome. And that's PPAHS.org. Is that right?
It definitely is, yes.
PPAHS. Okay, awesome. Thank you. Well, thank you so much, Mike. It was a pleasure having you on the show. I remember after our first conversation, we'd been chatting for about 45 minutes, and you just said we should have just pressed the record button, Chris, and we'd had your podcast. And that was spot on, because all this magic and this easy conversation was there right from the very beginning. And I appreciate that so much. I want to say thank you.
Oh, you're welcome. It's been a pleasure. This is something that I think you and I could talk about for days.
Days. And to all of you out there listening, thank you so much for joining us. If you enjoyed today's episode, please like, subscribe, and leave us a review. And don't forget, in many jurisdictions in Canada and the US, doctors, nurses, lawyers, and or attorneys can earn continuing ed credits just by tuning in and listening. You can catch this podcast on all the usual platforms and on the Inside Medical Malpractice YouTube channel if you'd like to see the video. And stay tuned over the next few episodes as we dive deeper into the world of patient safety with some malpractice case studies and talk to experts who truly understand these issues inside out. Goodbye for now, and take good care.